Good evening, everyone. I'm Alex Carolyn, Associate Editor with the Cancer History Project. Thank you for joining us for today's panel, International Perspectives in U.S. Cancer Center Leadership. The Cancer History Project is a free historical archive built collaboratively with the institutions that shaped oncology's history. Over the course of this year, we will be hosting more virtual panels on topics that bridge the gap between history and the state of oncology today. We invite you to join us for our next panel, hosted by Dr. Karen Knudsen, CEO of the American Cancer Society, on May 9th at 6 p.m. The topic will be Health Equity, Advocacy, and Access in the Community. A registration link is available in the chat. Today's event will be moderated by Dr. Narjust Duma, Associate Director of the Cancer Care Equity Program and Thoracic oncologist with the Lowe Center for Thoracic Oncology at Dana-Farber Cancer Institute. Today's panelists are Dr. Adekunle Odunsi, Director of University of Chicago Medicine Comprehensive Cancer Center, Dr. Peter Pisters, President of the University of Texas MD Anderson Cancer Center, Dr. Leon Platanius, Director of Robert H. Lurie Comprehensive Cancer Center of Northwestern University, and Dr. Cornelia Ulrich, Executive Director of the Comprehensive Cancer Center at Huntsman Cancer Institute. There will be a brief Q&A session at the end of this discussion. You can submit or vote on questions at any point during the conversation by clicking the Q&A button in the bottom right corner of your screen. And with that, I'll pass off the mic to Dr. Duma. Thank you for joining us for this discussion.
Thank you, everyone, and it's a true pleasure to have leaders in oncology with us. I often say that it's hard and we shouldn't reinvent the wheel. So learning for the wisdom that you cannot buy in a book that, sometimes we don't discuss in big conferences is important, right? In order to make it up there, it's good to have tips from the experts. This is with the hope to serve as motivation, not only for the current junior faculty, but for fellows, for trainees, medical students, and anyone that may be listening to us right now, or maybe listen to us tomorrow or next week. So first, we would love to get to know the four of you better. And we have discussed ahead of time, and as a matter of friends, respect, and colleagues, we're gonna be addressing each other by first name. So as I say, we want to hear a little bit about you. Can you, in 1 to 2 minutes, which is very hard, this is the hardest question of all, summarize your journey and why you decided to leave your home and everything you knew behind in order to pursue not only training, but other opportunities? I'm going to start with Leon, and then I will follow by Peter, and then Nelia, and then Kunle. Leon?
Thank you, Narjust. Thank you for moderating this, and thank you to the Cancer History Project for this panel. So, I was born in Athens, Greece, and I grew up in Athens. And, the way the system is in Greece, you have to compete. It was very competitive to get into medical school, but you will, when you went there, it was all free, and it was a good training. But what happened with me is there was a new medical school, the University of Patras, those days, that had just been created by professors, Greeks, who were in the US, and they had returned back. And the intention was to create a university there with American standards. So it was inspiring for us as students. We were hearing a lot about it. They were using multiple choice questions for exams that was not in the other schools. It was very interesting. And somehow I got, I got connected. I got inspired about the idea of coming here to do my clinical training. And, interestingly, I had tried also to go to Australia. I had applied. I had tried to go to England. They would not take me then. But I was lucky, and there was a research position at NIH because one of my professors who had been on sabbatical there decided to come back, and accidentally I met him and he was nice enough to, to connect me and to get this position. Anyway, to make a long story short, that's how I got to the US. I went first at NIH, and after that, passed my exams. I went to New York to do my residency, and then I moved to Chicago in 1989 at the University of Chicago at that time, where Kunle is now as a fellow. And since then, I stayed in Chicago, and at some point, I became director of the Cancer Center. That's my story.
I think it's hard to summarize, from research fellow, and then I became director of the Cancer Center.
I took some steps. It was not so straightforward, but,
And it's good to learn from you because, we all have those rejections that we still remember, and they made us stronger and move us forward. Peter, can you tell us this micro story about your journey?
Certainly. It's great to be with all of you. Well, I was born in a small town in Southwest Ontario. And when I was 10 years old, our family moved to the United States for 4 years. And in those 4 years, I acquired two things that were very important later in life. The first was a love of baseball. And the second one was a green card. We went back to Canada. I went to high school and went to college and eventually went to medical school there. But because I had a green card, the immigration opportunities were open to me. And when I graduated from medical school, my wife, who was a classmate, and I were one of 106 in our class, and we were the only two that went to the United States. We went to the US because it was my belief that I could get better training there. And we landed in New York City. I did my residency there. My wife was at Cornell, and that created a great environment for the two of us to thrive at the early stages of our careers. I was then recruited out of Sloan Kettering to MD Anderson, came to MD Anderson, was a surgeon in academic surgery for a long time, got more involved in administration, eventually was a vice president at MD Anderson. And then I left MD Anderson for a while, went back to Canada as the health system CEO in Toronto. Leading the group of hospitals that represents the main teaching hospitals for the University of Toronto University Health Network. That was tremendous experience for me, my first job as a CEO. And then when the opportunity opened up here at MD Anderson, they said, "Are you interested?" I said, "Absolutely, I am. I love the institution, I love the culture, and I was fundamentally interested in cancer and everything that we could give back to cancer patients and their families." And that's what brought me back into this role.
I really love the story. There's come and then you go back, and there's the common denominator of New York City. Nelia, can you tell us a little bit about your journey?
Well, mine was really more a sequence of random events rather than a dedicated plan. So I grew up in Germany. I was a first-gen student, first one on my family to go to university. And while I was at the university studying biology, I applied for a Fulbright scholarship without really knowing much about the US. But then that summer, I explored the US universities and traveled around and was really impressed. I was very lucky to receive the Fulbright scholarship that brought me to Oregon State University in 1991. And there I really learned a very different way of learning and student engagement. And for the very first time, I encountered any female professors in my field of study and professors with a family, while I really had been discouraged in Germany to even imagine being a biologist with a family. And so this was really motivating and just made me rethink what I might be able to do. And after my master's degree, I decided to apply for a PhD program because I really found the way of learning and student engagement in the US so much more interactive and motivating. I did my PhD at the University of Washington and the Fred Hutchinson Cancer Research Center. I became faculty at the Fred Hutch, advanced to full professor and leadership there. And then I did what Peter did. I went back to Germany, to my home country in 2009, and I co-led Germany's first comprehensive cancer center, the National Center for Tumor Diseases in Heidelberg. And I did that for 5 years as bringing back myself as a role model, I think, in that environment. Then I was offered the opportunity at Huntsman Cancer Institute, which is really a cancer center here in Utah with tremendous growth and an exceptional, really fun leadership team. And I couldn't say no to that. I came back in 2014 and became Cancer Center Director in 2018.
Thank you for sharing that with us. It's very interesting to hear that two of you went back and then came back. So, Kunle, can you tell us about your journey?
Yes, thank you. My journey started obviously from Nigeria. I was born in Nigeria, went to medical school in Nigeria. While in medical school, a number of events drew me to cancer and cancer research. One was really just some of the professors. These were Nigerian, US trained professors who were in the medical school. I mean, they were just the smartest, we looked up to them. And they really inspired us as young medical students at the time. After medical school, I transitioned to the United Kingdom, where I trained in obstetrics and gynecology. And then I came across also some very talented gynecologic oncology surgeons and science and researchers. At that time, CA125 had just been discovered for ovarian cancer. There was a lot of buzz about having a biomarker for ovarian cancer, a lot of research going on. It just, drew my attention that this was something that I wanted to do. So after Cambridge, that was where I had my clinical training. I was able to apply for a research fellowship through the Royal College of Obstetricians and Gynecologists to be able to go to Oxford. And there I went into the lab and did research leading to a PhD. And after that, what next? By this time, I had completed the training in England. I was a member of the Royal College of OBGYN. But what I wanted to do was gynecologic oncology. At that time, there were only about 3 training spots in the entire country. So it was so difficult to get into this specialty. So I had to transition to the United States. Of course, that meant starting my residency all over again. So it was a 4-year residency at the Yale School of Medicine. Went on to Roswell Park for my fellowship in gynecologic oncology. And then I stayed on faculty at Roswell Park for 20 years before being recruited to University of Chicago about a year ago, where I was recruited to be Cancer Center Director. Chicago, as you know, exceptional environment, and I'm just having fun with our leadership team and all of the things, the excitement that is going on.
Thank you. And it's a true pleasure to learn about your journey and the little things here in the country that, brought you back. This question is a little bit off script, but some of the big challenges for me when I moved to this country was getting used to the cuisine, or the food here. One of the things that's back home in Latin America, we don't eat that many sandwiches, like sandwich. We don't sandwich a lot of things. And a lot of things are rice, beans based. So that was hard for me, that there were so many sandwiches and it was hard. So Leon, what was very hard for you when you moved here about the cuisine that was unique? I think we have you on mute for now.
Sorry, yeah. So I wouldn't say it was hard, although I grew up in Greece and, Greek food is great. At the same time, I was used to unhealthy food and sandwiches. There were a lot of McDonald's and places like that in Athens. So there was, it didn't make a difference to me. It was, it was not hard.
And for you, Peter, what was that food that maybe in Texas, you're like, okay, this is different?
Well, I think for me, the adjustment, my parents were Dutch immigrants. And so at home, I was used to a Northern European cuisine. The Dutch are not necessarily known for their cuisine, but we had unique foods in our home environment. And then when we went to the States, I was exposed to a completely different way of eating. And of course, when we got to Texas, we learned to love margaritas and Tex-Mex.
Nelia, for you, how was that switch with the food?
Well, Germans are famous for some things, including bread and chocolate. And so I miss the bread, especially at the beginning, but for the chocolate, I just bring it back with me. Suitcase is full. whenever I come back to the US. So I still do that.
I think that's common for a lot of us. And Kunle, what is something that you miss or that was hard to adjust?
Yeah, I mean, like you, the Nigerian cuisine, it's rice and plantain and all of those types of food. So my adjustment actually took place when we moved to England. So I already adjusted to sandwiches and all of those, fish and fries, I think. Fish and chips is what it's called in England. So the adjustment was not too difficult when I made the transition eventually to the United States.
Well, thank you for sharing that. A little trick. So many of you may be wondering, why are we doing this? So we're doing this in part because we continue to lack representation in oncology leadership. It's not only about, our racial background, but there's lack of representation about people that may have trained outside the United States. It means MDs. There is gender disparities in leadership. So we're here to talk about this. And just as a sense of a little bit of background, it's important to mention that the Black and Hispanics in leadership and oncology are very small. I think we can count it, unfortunately, by hands, with one hand for each group. And then there's also significant gender disparities. And my next question is to Nelia, because you're one of the few women who's a cancer center director in the United States. Can you share with us some of those unique challenges that you may have faced, and what is your message for people like me and the new generation that's interested in joining the leadership?
Well, I could go on for a long time, but but there are also many opportunities. I have to say, maybe I'll talk first a little bit about Germany, because when I went back to Germany to become cancer center director there were only 6% female professors in medicine. And so my leadership role was very unusual. And I feel so much with some of our underrepresented minorities now, who are the only people of color in the room, because that was what I experienced there. So it's simply not something that people are not used to, and associating that role with it. For example, I've been asked to load the slides of a male colleague at a conference, right? That's pretty typical of what could have happened there. But I have to say, at Huntsman Cancer Institute, it's actually been a great benefit for me to succeed another woman director who really provides exceptional mentorship, and that's Mary Beckerly. We have a very diverse leadership team, and there's a lot that I learned throughout my entire journey in different cultures, and being the only one, there's, I think for women, definitely different communication patterns and identical styles that exist between a woman and man will be interpreted differently. And I think that's something we all are dealing with as we're trying to overcome our inherent biases that we have. And so there's a lot I could talk about, also about teams and mentorship of young women. But I feel overall it was an advantage for me to be a woman, to come to Germany, because I was somebody who had to be on the table, but I also was pulled in a lot of different directions. And I think that's the same a little bit now. We have only, I think, about 6% female cancer center directors in the US. And so there's more work to be done. And I really appreciate all my colleagues from all different backgrounds. And I think diversity really matters to find the best solutions.
Thank you for sharing that. And that's motivational to many of us. And this question is for the four of you. So you train away from home. Residency can be one of the hardest things that we do. I was talking to a colleague today, and I told her, at this stage, I don't think I could be an intern again. I don't think I have the physical and emotional and mental capacity to be an intern again. So through that journey, what are some of the, I want to measure 3 things that you learned to the journey of leaving family, friends behind. And for example, Peter left all his classmates in a different country. What are some of those 3 things that you learned in this journey that help you lead in oncology? And I'm going to start all the way around. So I'm going to start with Kunle first.
Yeah, that's a good question. I mean, the first thing that I will say has helped me as I reflect on my journey is just the ability to work with different types of people. Remember, I've lived now on 3 continents, in Africa, Europe, well, in UK, it's really not part of the European Union anymore, as well as in the United States. So the ability to be able to interact, work, collaborate with people from all kinds of backgrounds. So that's number one. Number 2 is tenacity. How do you persist even when you encounter disappointments and failures? How do you keep going? How do you pick yourself up? How do you learn from your experiences? So the very long path that I have taken has prepared me well to be able to deal with both success and failures. And then number 3 is just the breadth. I think the breadth and depth of experience of people's skills that comes with the long training. As you know, especially when you have those, you just talked about internship, when you have those long nights of calls and you just keep going, and yet you are dealing with all kinds of people. I think that journey has actually prepares you for leadership, and also to understand how to relate to both people who are your superiors, people who are junior to you. It's really a total package, I think.
Thank you so much. Nelia, what are those 3 things that you learned during this journey?
Well, I just want to second what Kunle said about bringing different perspectives to the table. And I think about different leadership models, funding models, health policy across Europe and the US. And I think I learned a lot about the impact that leaders can have on the culture and success of their own institution. And so I feel we have probably a little more of a balanced perspective as international leaders, that we can think outside the box. Persistence and taking opportunities when they present themselves, and being a little bit, I'm a very curious person, and there's nothing I couldn't imagine doing almost, except for maybe skydiving. And so I'm a person who really is very curious about many different aspects of cancer. I care a lot about my faculty, my students, and what they're doing. And I think that overall curiosity paired with perspective and persistence or tenacity is very important.
Thank you so much. I think we continue to see the persistent as a persistent subject. So Peter, what are those things that through your journey help you lead and we help the next generation?
Such a great question. I think for me, probably the first thing, possibly the most important, is the value of empathy. And the ability to see the experience through the eyes of the patient and the family, understand the emotions that they are experiencing, and adjust what you do using empathy as your guide. That was so powerful for me as a surgical resident, seeing all kinds of patients in all kinds of difficult situations, sometimes self-inflicted, sometimes as a result of trauma, sometimes as a result of cancer. That's the first thing. I think the second thing that I found so helpful was to understand the value of teams, or to consider teaming as a verb, and to study how teams function and what makes teams effective. Because ultimately, what we do as leaders is coordinate team function and analyze team dynamics. And so understanding teaming as a verb and understanding the principles and makeup of a strong and effective team. The third thing I think that was helpful for me is understanding the value of emotional intelligence and how critical it is to our success as leaders. As a surgical resident, your emotions get pushed and your buttons get pushed in a whole variety of ways. And if you can learn to recognize those emotions in yourself, and very importantly, to self-regulate those emotions, then you become a better person, not just at work, but at home also. And so I think these three things have really helped me to become a better leader over time.
Thank you so much. Leon, what are those three things that you learned in this journey that started with Athens and it ended in Chicago?
Right. Well, one thing that is important to remember is when you leave your country, especially if your country is far, and you immigrate here, your whole world changes. And things are more difficult. Like you always worried if something happens to my family in Europe or whatever. You deal with something much more difficult. You change completely. You do that because you want to do it. But this is something that defines you too. You understand more the difficulties that your patients have too. You can relate more when you see other people and all their problems. When I did my residency in New York, it was at the peak of the AIDS epidemic. And it was at that time, it was, I was in a hospital. One of the hospitals I was rotating was a county hospital. And it was talking about overwhelmed hospitals. It was like a war zone with patients intubated on regular floors. It was really crazy how intense it was. And this intensity combined with just having, arrived here from somewhere else, makes you tougher and, helps you to prepare with issues of leadership. And one thing that the way I operate at least, is to never give up. If you have a goal and you think that this goal is worth it, to keep insisting, at some point it will happen. So I think that's the most important lesson I learned.
Thank you to the four of you. I think just to summarize, persistent, it was a common theme, taking opportunities when they come and understanding that there's always risk. But remember, what we do this for is for our patients, and remember that empathy will move us forward. We do have a question on the chat from the amazing Dr. Otis Bradley that I think it will be important to address before we even run out of time. So Dr. Bradley asks, the US healthcare system is so different in terms of insurance payment compared to Nigeria, Greece, Germany, or Canada. How hard was the adjustment? Were all these disparities and challenges with healthcare a surprise to you? I will start with Peter.
Well, it's a very interesting question, and many people, particularly Americans, believe that Nirvana is the Canadian healthcare system. And as I experienced it, I found that was not true. And when you look at developed countries and you order them like with the Commonwealth does, you can see Canada ranks out at number 10 or number 11. Canadians are hardwired to compare themselves to Americans. And of course, America is at number 12 or number 13. And so Canadians are pretty complacent about the system that they have. The strength of the system is universal access that's based on residency. And of course, the fundamental flaw in our system in America is that insurance and therefore access is linked to employment. And that creates tremendous challenges and large groups of individuals who do not have access to the front door of American medicine because they don't have employment or their employer doesn't offer insurance. And seeing that really in two roles as a CEO, I think was very, very powerful for me, because I could see both the strengths associated with universal access as well as a lot of the limitations associated with that as it relates to the ability to perform research and the ability to see centers of excellence such as MD Anderson. You don't see institutions of excellence or elite institutions in an environment that really is designed to elevate the median, but not to support a pathway to excellence.
Thank you, Peter. Kunle, how was it different between not only Nigeria, but also the UK when it comes to payment, reimbursement, and disparities?
Yeah, that's a good question. So I have seen healthcare in an under-resourced environment, that is Nigeria. While I was in medical school, And some of those issues persist in a country like Nigeria, where the healthcare system is highly fragmented. It's not very well coordinated. So it's truly a low resource setting. So I've seen that. In the United Kingdom, the healthcare system is more the welfare system, universal access. I've seen some of the limitations. It has its strengths, but it also has weaknesses. Prolonged patient wait times for surgery, for procedures, and so on and so forth. But as Peter pointed out, I think the United States health system really has the opportunity to be the best in the world because of so many factors. This is an environment where we care about research, innovation, but unfortunately, we still struggle with access. In fact, if you look at the numbers of the 600,000 cancer patients that die each year in the United States, about 1 in 5 of them could be prevented if they have access to high quality care. So we have a lot of work to do in balancing highly sophisticated medical care with access for the regular person who maybe does not have insurance or is underinsured.
Thank you. Nelia, you were a cancer center director in 2 different settings. So you saw it from above. What are some of these differences you noticed?
Well, first of all, let me tell you, I got a degree in health services research, and I had the pleasure of teaching in a class on international healthcare systems to medical students. And there were 3 systems: the British, the US, the British, the US, and the German that we talked about, and the Canadian, but let's forget that. But we compared it to cars. We had the British were always like, it's like a bus, right? It gets you approximately where you want to go. It's kind of reliable, and you somehow get there, and it's cheap, right? The American healthcare system was like a truck with a lot of holes, gaps, problems that would drive or not drive, and you were either lucky or not. And the German healthcare system, I still would say, despite all the problems that we all think because it's too expensive, is a Mercedes coverage. We have, like, not only after birth, you get to stay in the hospital as long as you like, you also have a midwife come to your house. You have like health spa visits that get covered when you have burnout or when you're tired, and that's for mothers or for, you sense a lot of passion here, right? So I just want to say what this has actually been a big challenge. Like for me, it pains me to see so many wonderful things in the US, but then how many patients do not have the access they need, cannot receive the care they need, have not the ability to get the treatments in many cases as well. And the big difference between Germany and the US is health insurance is universal. It's not just public, it's also private, but pretty much everything is covered, and everybody knows that. It's a minimum coverage. And so our billing is about 4% of the cost. And so that all that money can go into healthcare, and it avoids this huge administrative and billing overhead. And that's where I would love for this country to go for the benefit of all. But I also love the research and care integration. I think that's amazing in the US. I think team science is much more developed, and the ability for people to speak up and bring ideas to the table without much hierarchy is really a huge strength for the United States. And so this is my 2 faces of the US healthcare system.
So first, I'm going to use that analogy now when I talk to my students. So you can trademark it because we're going to use it. And we need to talk a little bit more about that. SPA for burnout, those are applied to physicians too. Does that cover us?
There's a strong history of like places, beautiful places you can go to, and it's paid for several weeks. And it's not just rehab after an illness, but it's also after, like, it's just there is a strong belief in the well-being of people.
Thank you. Leon, as I research trips to Germany, can you share with us the difference between this and the care in Greece?
Well, I did not really practice in Greece. I finished medical school and I came here But I have to say, although there was universal coverage in Greece those days, the system was not working well. It was not what we just heard from Nelly. It was very dysfunctional those days. Now that it has improved a lot, it's much better. But when I left in the 80s, it was not, that good. Now, coming here, and I think what Otis asked, if we found the disparities surprising. And, I have been in both. I have worked as an intern and resident in a county hospital, and then I have been in great hospitals. And yes, the disparities were stunning, especially the days when I was in New York in the peak of the AIDS epidemic. I was really shocked of how hard it was for these people being there with not limited resources, but with an overwhelmed health system from many people being sick. So there is no question we have major disparities. Peter addressed that, and everybody else pointed that. We still have the most advanced medicine in the world. That's why we are all here, because you can do things here, you can do research, and you have the opportunity to do all that. But like Kunle, I think we can do even better. So it's a complicated question, but the disparities clearly are not something that makes sense. Everybody should have some basic health coverage. That's a basic human right, pretty much, to have to be treated. So that's what I think.
And I think it's important to remember, not only for the people that are listening, but the people that will listen in the future, a lot of these disparities not only are when the patient enters the clinic or the hospital, they're secondary to social determinants of health and environment that brew those disparities and brew those challenges, and we see them. So it's not only about having that insurance card, but it's also about where do you live? Do you have a food desert? Do you have transportation?
Absolutely.
So much research that show that if your patient has a PD-L1 100%, that's something with lung cancer for immunotherapy. But if the patient doesn't have a way to get to the cancer center, that response rate is still 0%. So this is a very important question because we're learning and continue to evolve. There is another question on the chat that I think is very important. Many of us have faced discrimination, bias. Some of you may have been in my ASCO Voices presentation last year, in which I would cry from the parking lot of the hospital all the way to my apartment because I was often seen, feel like I didn't belong or seen as underqualified because I didn't go to medical school here. So for you, did you experience any challenges or xenophobia, like the question is posted in the Q&A, or seen as less qualified just because you didn't went to medical school here? I'm going to start with Kunle, and then we will go the other way.
Yeah, that's a good question. I think what I found is that once you, so I came to study residency directly, just like Leon and others. Once you get into this system, and the first thing is you need to prove yourself. I think people look at you with suspicion. But once you prove yourself and you're accepted, I think you're fine. That was my experience during residency. But to the point about people looking at, at you, whether to kind of reflect that you are less qualified or less competent. I experienced that when I was applying for fellowship. There were two or three people in my residency class that were applying for fellowship. I was IMG. I'm also Black. When I applied for fellowship from Yale, I think I got only 3 invitations for fellowship, whereas my counterparts got like 20 invitations for fellowship. So what's the explanation for that? First of all, my name maybe is not familiar. My medical school is, is outside of the United States. all of those strikes. So yes, it does exist, but as we've all pointed out, I think tenacity, persistence, don't give up, just keep, drive through whatever barriers and obstacles that stand in the way. So I did not let that detract me from the big picture, from the goal of what I wanted to accomplish. And I was fortunate to get my fellowship done at Roswell Park Comprehensive Cancer Center.
And I think that's very important that we have seen as a subject here, is that if we given the opportunity, we will excel, because we have sacrificed much by leaving everything behind. And Leo mentioned this, and many of you mentioned this. When our family members get sick, it's quite hard. And then you're in residency, you're so far away. And let's all be honest, how many of us during training could have afforded a ticket back home, right? Like, I remember being an intern, and my dad helped me to go back because, it's very financially challenging. So Leon, same question to you. Were you treated different? Were you seen differently?
So, I don't think I have experienced xenophobia in the medical field. I think that's why we're here, because the country welcomes other people. So, and I think we had the chance that we, normally, I told you, I tried to go to England. There was no way I could find a position there. But here you can do it. So personally, I have not experienced directly xenophobia in the medical field, but I had, at the beginning, many years ago, there have been incidents outside my profession that I have felt some xenophobia long time ago, but I ignored it. It doesn't, I just never paid attention. But I think, although Kunle has, a different experience, in general, this country is welcoming of FMGs, and there is a long tradition and history of people coming and training here. So I think that I think we should separate xenophobia as an incident with medical, with medical training. I don't think it's much in the U.S. medicine, but that's my view. So.
Thank you for sharing that with us, Peter. How was your transition when you went to medical school in Canada, and then you went to surgical residency here, which is a very unique setting?
Well, when I made the transition from medical school and I landed at Bellevue Hospital in New York, it was a big change for me. But New York and this country in general are a melting pot. And just like Leon says, I found people to be, generally speaking, very welcoming. The medical staff at NYU and at Bellevue Hospital was really an international medical staff. And so I really felt like I fit in. And it was individuals and teams made up of people from different places in the United States and from other countries that were working to care for the patients. So I really embraced that and learned a lot from the experience of being in a multicultural environment in the early years of my training.
Thank you, Peter. Nelia, this is my question. You came from Germany all the way to the Northwest.
Well, I personally have not encountered any xenophobia, but let me talk to you a little bit about something else. I mean, Germany comes with a history that involves the Holocaust. And in Germany, I had not met any Jewish friends or colleagues. And so this is always in the back of people's minds still. And I have now so many wonderful friends with a Jewish background. And why I'm bringing this up is I think it's just because we as leaders also have responsibility to think about that as we have conflicts in the world where people are experiencing immense pain. And we need to bring these people together and still make sure they see each other as humans and not as representative of a culture. When I came with my Fulbright, they told me, if you're a nice person, they're gonna remember you as Nelly. If you're a bad person, they'll remember you as German. So I think we are representatives of our culture, and we can bring that in and can also help bring others together to make sure that people see each other as people.
Thank you. And that's very important because there's many trainees that have descent for where conflict is happening right now. And it's important to support them through this journey because they're here training, but their family is back. They may not be back home anymore. And it's important to understand that. So we're about to run out of time. But I have one question that I need to ask before we end. And my question is, what is one thing, honestly, that doesn't really matter in regards to a career in academic oncology that you really thought it mattered, but now when you're here, you're like, doesn't really matter? I'm going to start with Peter.
Great question. I think in our environment, there is too much focus on academic productivity and not enough focus on the holistic contributions of people to their institutions. And I think that when we bring an approach that is really focused on how do we build a World Series team, how do we recognize the contributions of many people, and that you can play a variety of different roles and you're just as valuable a contributor to the team.
Thank you. Nelia, what is something that you really thought it mattered, but it really doesn't?
What really doesn't matter is your own ego. And you need to let your own ego go and be part of the team. And so I think the one thing also that you had asked is like, what's your mistakes you made during your career? And that ties in with what Peter just said. Sometimes I really prioritized work a lot more. And later I learned that the lunch is more important, the relationship, rather than the paper that goes out.
And that's good to hear for many of us that are very early in our career and are having lunch in front of the computer as we click more billing and more things in Epic. Kunle, what is something that you realize it doesn't matter?
Yeah, I think one thing that I think really doesn't matter is just to this ability to be able to give up and think beyond yourself, think of the, to be able to give up some of the things that are really your own, if I can use that word, but to focus more on the team is what I'm finding. The other thing that I will add, I think we haven't talked about family. Family really matters. I know you're asking about what doesn't matter, but I will go on to say family matters as you go along in the career trajectory, also to make sure that we pay attention to our families. And we recognize that in people that we work with, even as leaders, to make sure that we encourage a work-life balance.
Liam, same question to you.
Okay. So I think what it really doesn't matter is that you are a foreigner. When I came in this country, it never crossed my mind that I would be director at Northwestern at some point. And you just realize that everything is possible. You can do everything you want if you are determined. So being a foreigner, coming from being an immigrant, doesn't matter. You can get through it and be successful. That's what I realized, at least.
I think that's a very important message because sometimes we feel that we can't. And I can tell you, like from the bottom of my heart, when I left Venezuela, that I never thought we were going to work in Harvard, to be honest. Like it wasn't even the wildest dream of being an assistant professor here at 30. I was almost saying my age in my 30s. So we have one question in the chat as we're coming to the Q&A section of these podcasts. We need to talk about this. And it's, do you have any message for Ukrainian refugee scientists? Who would like to start first?
What was the question? If you have any message?
The question is, do you have any message for Ukrainian refugee scientists?
Okay. Well, go ahead.
Well, I met with my Ukrainian faculty, and my former postdoc is Ukrainian. I guess the key message is just we feel with you, and we really feel your pain. And I think having that international background and being a little bit closer with the home country to this, we can never really understand what you're going through right now, but we're there for you.
Leon?
I will second that. I mean, having an international background brings us closer to them. And I think we can sense a little more their pain and suffering. And clearly, they're in our thoughts and they have our support, and anything we can do as cancer center directors to make it easier for them. That's exactly what we would like to do.
Peter?
I will echo those comments. Just going to say, I will echo those comments as well, that we empathize, we feel their pain, and we stand by ready to help in whatever way we can.
Peter?
Yeah, I think what I would add to what others have said is that this is clearly a humanitarian crisis of unprecedented proportions. We're also seeing a response in the Ukraine from Zelensky, from NATO, from the international community, from the business community that none of us could have ever predicted. The strength and resolve of the Ukrainian people is something that we will be talking about for generations. What they're doing to protect their country, their sovereignty, is something that we all admire as Americans. And the whole world is behind them at this moment in time. And we will never forget what we are learning right now.
Thank you so much. And there's a very strong message that I hope it gets not only to Ukrainian refugee scientists, but anyone has been affected their career or their life with any conflict. We have one last question and we only have 6 minutes, and this is from Dr. Bradley. Does the US healthcare system stress screening and treatment more than other countries? So what I think what's trying to say is, do we push more for screening and treatment more than other countries? Anybody would like to start answering that one? Nelia, you can go ahead.
Sure, I'll go first. I think, yes, definitely compared to the German system, but Germany is really struggling with its colorectal cancer screening. And that's very sad, that's very sad, because it would be so easy to do a better job there and just encourage everybody to come in. But there's also a question about treatment and over-treatment, and what are patients' wishes, and is more treatment always better? And I think there's a more healthy relationship with that dialogue in Germany perhaps than here.
Anybody else would like to comment on that?
Speaking of cancer screening, for sure, Ontario had an exemplary system that exceeds anything that I've seen in the United States. In a publicly funded, publicly administered healthcare system, the province, the Ministry of Health has your information, and they would routinely notify you when you were due for a mammogram or a sigmoidoscopy or occult blood testing. It was done on a systematic, data-driven way using a centralized database. It's probably a model for other provinces and certainly for other jurisdictions in how to use data and use a centralized system that's easier to do, obviously, when there's a single payer, and facilitate screening of 16 million people in an organized, data-driven way.
And I can imagine that data can be mined. I think Nelly and I, as health service researchers, we're like, oh, that data can be utilized for research as well. Kunle, what was the difference between treatment in Nigeria, for cancer particularly, versus the US?
So in Nigeria, the treatment for cancer is very fragmented. The the healthcare coverage system is really not very strong, and patients have to pay out of pocket for the most part. If you are wealthy, you go out of the country, you go to UK or United States or other countries for your treatment. Essentially, if you are not wealthy, if you cannot afford it, it's almost a death sentence right away. But what I have to say is that I think the system in the United Kingdom, similar to the system in Ontario, also has this national call and recall system, whereby you get reminded that it's time for your screening. And this is a national centralized method whereby wherever you live, even if you move from one region to the other, you still get a letter in the mail saying, you missed your pap smear, or you missed your mammogram, or your colonoscopy. So I think that kind of system is likely to enhance, earlier detection of cancers. And I see that type of model, along with the one that Peter described, as potentially a model that we should try and shoot for in the United States.
Thank you. And Liam?
Yeah, I don't have much to add. I think the US prevention system is probably, depending on where you are, more advanced than other areas. But there is one issue unrelated to that I wanted to bring up before we close. I can do it now, or
Go ahead. We have 1 minute.
One thing that I had in mind when this interview came up, when this panel came up, was to discuss training grants. Training grants right now do not allow people from other countries to participate unless they become US citizens or get the green card. And I think there should be an appeal to NIH to change that. I don't think it makes sense to exclude international people from training grants. In fact, sometimes they have problems filling spots and so on. And I just wanted to bring it up. I don't know how others feel here, but I think this is something long overdue.
And I think that's true. And Leon, it does not only apply to the NIH and NCI. I also have seen, because I have many of my mentees that are in J1 visas, also grants from foundations are requesting to be a US citizen in order to apply. What is the experience for any of the other panelists with that?
I agree 100%. I think we have so many brilliant minds coming here, of people from all over the world. I wasn't able to get a K award, but that forced me to write my first R01, but the pay lines were 25%, not 9%. And so I got an R01, but it really limits the ability of young international trainees or faculty by not being able to have access to training grants. And it limits the US's potential through that as well.
It changes diversity, right? So the pool is not as diverse, and diversity equals innovation. Kunle and Peter, do you have anything to add there as we close?
Well,
Really?
I think, sure. I think what we're bumping up against is strategic immigration policy. And what we are needing as a country is a strategic approach to immigration, and understanding that gifted and talented people should be kept in our country to help us foster innovation and discovery for the rest of humanity. Right now, we operate some of the finest universities in the world. And when individuals finish degree granting programs there, they're sent back to their own countries. Instead of doing what Steve Jobs said years ago, anybody finishing a PhD or master's program in the United States in graduate training should have a green card stapled to their diploma.
Kunle, I love that idea.
I love the idea as well. So I agree. I think we should always be looking for talent. That is what has driven this country. This is a country of immigrants. We just happen to be, the immigrants, for the ones that came here, So I think just driving for talent, looking for talents, and the training grants It's an opportunity to identify talents that we can retain in our system. That is how we're going to keep driving innovation.
Thank you to the four of you, and thank you, Liam, for bringing that, because it's quite important as we transition fellows and postdocs into a career in academia. And we've seen that with COVID. This is my remark. We have seen an exodus of brilliant minds leaving academia. And if we continue to put obstacles for international brilliant minds, the exodus is only expected to continue. And I just can tell you how many of my friends had left. And it's sad. So I hope that people find this inspirational, but also an opportunity to take action and advocate. Thank you all. And now I'm going to pass it to Alex.
Thank you so much, everyone. Thank you, Dr. Duma, for leading today's insightful conversation. And thank you to today's panelists for your time and really important perspectives. To our viewers, if you'd like to be informed of any upcoming events, please click the link in the chat. And thank you all for joining us tonight.